Greetings and welcome to this session of Springboard. My name is Carol Underwood. I'm a sociologist at the Center for Communication Programs, a faculty member in the Department of Health, Behavior, and Society at the Johns Hopkins Bloomberg School of Public Health, and a member of the research team for Breakthrough Action. Today I will give a short overview about the social determinants of health and briefly discuss how those determinants are related to or affected by social structure and human agency. As social and behavior change practitioners and or researchers, I'm sure you are well aware that manifest health inequalities exist and persist between regions, between countries, and within countries. Indeed, morbidity rates and life expectancy often vary dramatically within cities, often by neighborhood, and those differences are typically linked to social class or social status or the accumulation of wealth. So, what are those social determinants? According to the World Health Organization, the conditions in which people are born, grow, live, work, and age are social determinants of health. As you can see right from the get-go, the conditions in which we are born are not something that we as individuals have any control over. We often aren't able to even determine where we will live or work or age. The WHO notes further that these conditions are shaped by the distribution of money, power, and resources at global, national, and local levels. Again, the distribution of resources is something beyond the control of most individuals. Research shows that social determinants of health are the underlying causes of today's major societal health dilemmas, including maternal and newborn child health outcomes, infectious disease morbidity and mortality, as well as the non-communicable diseases such as obesity, heart disease, diabetes, and depression. So now that we've argued that the social determinants of health are the underlying causes of all of these problems, what are some key social determinants of health? Well, they're in these broad areas of economics, agricultural and food resources, education, whether or not healthcare is available, accessible, and to whom, social factors, social relationships, and the environment. So when we think about it, how social determinants could influence health, we certainly can imagine or we know that economic opportunities influence health outcomes, as do educational opportunities, and what type of occupation one has, or in one's employment status, workplace safety, gender inequity, racial segregation. These all influence what kinds of health outcomes we'll have, what resources we'll be able to bring to bear, and then how that will affect our health and well-being. And certainly food insecurity and whether or not we have access to nutritious food options. Do we have access to safe housing and stable housing? Other factors that can influence our health that are at this upstream level are things like early childhood experiences and development. Whether or not we live in a community that's inclusive, or do we have marginalized groups, or in fact, we part of that marginalized group. Is social support common in our community? What about the crime rates? We know that exposure to violent behavior certainly affects our morbidity and mortality. The availability of transportation influences not only whether we have access to clinics, but also to markets, to employment opportunities, to education. And the neighborhood conditions in which we live can certainly affect our well-being if we live in an area which is near a major dump or where there's pollution. Will have our health negatively affected. And of course, access to clean drinking water, clean air, toxin-free environments are important for health and well-being, as are recreational and leisure opportunities. So now that we've, I hope, established that these factors, these upstream factors, affect our health, you might want to ask, well, how does that happen? So we've seen that there's a correlation, there's a relationship between educational attainment or employment status or which neighborhood we live in and our health. But how does that affect our health? What are the processes between these upstream factors and our health at the individual level? You might argue that educational attainment, wealth quintile, gender, ethnicity are already included in epidemiological analyses. But if you think about it, they're included at the individual level. So if my educational attainment is assigned to me as if I were an isolated individual, but in fact, we live in communities, and my educational attainment or my occupation or my social status only have meaning within my relationship. So these are relational factors, not individual level factors. But what epidemiology has done is transmuted these relational factors into individual level factors. And so the processes through which social determinants affect health are often left unexplained. But sociological theory and other social science theory can help us understand these mechanisms. Today I'm really only going to focus on one theory, but there are others that we could bring to bear. But first we need to step back and think about what is it that brings about changes in the social determinants of health? How can we affect those? How can we affect the distribution of money, power, and resources, as the WHO says is necessary? This is actually a perennial question for social scientists who have, for decades, even more than a century now, ask as their central question, what causes social change? What enables social change? Is it the structure? Is it the system? Or is it human agency? Is it the individual taking action? So first we need some definitions. Structure constitutes the socially determined rules and systems under which we live. So structure determines who has access to which resources and under what conditions, and also with what degree of control. And these resources can include many things, but certainly include material resources with which we're all familiar, financial and physical resources, the kind of income, whether or not we can get loans, whether or not we have access to housing. These material resources are very important, but also discursive resources. To what extent can we affect the agenda, the social narrative or discourse in our communities? What about educational resources or the power to decide, the power to act? These are all determined by rules within the larger system. And then structure is often opposed to agency or human agency. And agency is action that is reflective, purposive, and intentional. So we should distinguish this from behavior. Behavior can be reflective, purposive, and intentional, but behavior can also be irrational, unplanned, and without a lot of thought. So we're thinking here about agency, the capacity for action, which is inherent in humans. We can all take action. But the extent to which we can take action, the quantity of action, the quality of agency comes from our milieu, the social milieu within which we live. To paraphrase Marx, we make our own choices, but not in conditions of our own choosing. So then that question comes, well, so why does structure matter? I hope that through this discussion it's started to become clear that those rules and regulations of how resources are distributed and controlled or structures can impede or enable social change. And we're, of course, very concerned about social change. So I'll take this moment now to define social change. Social scientists consider social change occurs when the overall structure is altered by, again, changing the distribution of resources. And we've talked about those resources. Social change is distinct from cultural change. Cultural change is when we have new ways of acting, new frames of reference, maybe new words that we use in different ways. We may interact with our elders in a different way, or with children in a different way. These could be changes in culture. There may be changes in the way communities are organized. But if it doesn't change access to resources, it would be considered cultural change and not social change. And then these both are, of course, distinct from individual or behavioral change, which would be when changes in beliefs and attitudes and behavior are restricted to individuals. So now, as we think about about social change and structure and agency and which causes what, a helpful or useful way to look at it is through structuration theory, which is Anthony Giddens' theory. He argues that structure and agency actually constitute a duality. And he's not the only social scientist who does this or sociologist who does this, but he's the most well known. He argues that structure is given. Again, we're born into systems. The structure pre-exists us. And so we're not entirely free to choose. We always have restrictions, or most of us, I suppose all of us always have some restrictions and constraints. But at the same time, we also have agency. And that agency, that human action, can produce social structure. It may just reproduce it. The same social structure, inequitable as it was or is, may just be reproduced. Or we can use agency to reconfigure social structure, that is, bringing about social change. As Giddens argues, social structures are both constituted by human agency and yet at the same time are their very medium of this constitution. So in reconciling structure and agency, again, we think of agency refers to people's capacity to act. And to act is to exert power. To believe you can do something is not to exert power. It's only a belief, like self-efficacy. It's a conviction that you can act, but it's not an action, so it's not exerting power. Social systems and structures are constituted or reconstituted through agency and through social practices of people working in concert. And I just want to take a moment to talk about another concept that is very commonly discussed among SBC professionals, and that's the idea of social norms. So social norms are, as you know, probably the unwritten rules and standards that are understood by members of a group. So when I'm in a group, I know what I'm expected to do, what's acceptable behavior, but I also know the rules or guidelines about what's forbidden, what people would condemn as undesirable behavior. And social norms can have a huge influence on what we do or do not do, but they do not have the force of law, so they are distinct from that. Yet they can be as powerful as laws. There's two types of social norms that are commonly described in the literature. The first is descriptive norms, or what people do, so what is my perception of what most people do in any given situation? That would be my understanding of descriptive norms. But injunctive norms characterize the perception of what people approve or disapprove, or what I ought to do or other people ought to do. It's important to remember that when changes in social norms are insulated, that is, the changes, these normative changes do not lead to alterations in access to or control of resources, the change is normative and not structural. Now, I can't go into this at this point. So certainly, social normative change can bring about structural change, but it absolutely does not always or inevitably bring about structural change. And we can think about norms that have changed, that people having, like maybe adolescents having access to contraception. If this becomes accepted, it doesn't necessarily change their access to resources like employment opportunities or loans or so forth. So now that we've talked about social determinants of health in a bit of detail, I'm sure you're wondering, okay, let's assume that this is right, that social determinants of health are the underlying causes of so many health problems and dilemmas. So as SBC practitioners, where should we intervene? I'm sure most of you, I won't say all, but most of you are familiar with social ecological model, and you recognize that we can't intervene at only one level. We can't only intervene at the individual level or the institutional level or any of these levels here. But I think you'll also agree that most SBC interventions do take place at the individual level, some at interpersonal level, some, of course, at institutional level, but we're least likely to act at the structural level as SBC practitioners. Yet, Frieden's health impact pyramid points to the fact, as you can see in this diagram, that the greatest impact at the population level will be when we have interventions that affect socioeconomic factors. Again, things like access to resources, employment, financial resources, education, power, and so forth. And so the least effect at the population level will be when we focus on counseling and education. And the greatest effect at the population level actually requires the least individual effort, whereas the smallest effect at the population level requires the most individual effort. So let's turn now to a little more detail to try to understand this. This is an example of the CDC using Frieden's health impact pyramid. And it shows that we can have the largest impact if we can affect socioeconomic factors, things like poverty, education, housing, and inequality in society. The next level up would have the next most impact, and that would be changing when we can change the context, when we can make individuals' default decisions healthy decisions. So if there are tobacco taxes, people are less likely to purchase cigarettes and smoke. When we have regulations that do not permit the use of trans fat in foods, people are naturally going to have a healthier choice in not eating trans fats. There are also long-lasting protective interventions, things like immunizations and cancer screening at the clinical level. We may have prescriptions for different diseases. And then at the individual level, we'd have counseling and education, encouraging people to eat healthy and be physically active. Now, all of these levels are important, but the point of this pyramid is just pointing out that we'll have the greatest impact if we can work at the on socioeconomic factors, which are also social determinants of health. And then I'd just like to show you one other example. This is on alcohol, and again, even with something like alcohol, reducing poverty and increasing people's education and employment opportunities will reduce the likelihood that they will suffer from alcohol abuse. And then going up the pyramid, you can again see where different levels of intervention, if we have alcohol excise taxes or reduce the number of alcohol outlets, there will be a considerable population-based impact. And then if we go to the top of the pyramid with alcohol education and counseling, we will have some impact, but it will have the smallest impact, and it will require the most individual level effort, but the least political will be needed. So in summary, I know this has been very quick, and I'll be happy to answer questions. I have discussed the fact that, or reminded ourselves that health inequalities exist between regions, between countries, and within cities, and that social determinants of health are the underlying causes of health inequalities across the world. When we treat those social determinants as if they were individual level attributes, we overlook the processes that can help us understand how structural factors affect health. So to address social determinants, the SBC community needs to think critically and strategically about ways to enable structural change, including ways to change policies and regulations and encourage their enforcement. Also, create more equitable access to resources to enable human agency action, and take into consideration to be cognizant of the real barriers that people with relatively few resources have, or that they face when trying to bring about change, to change their behaviors. So finally, I'd just like to leave you with a thought from Margot Britton. And in a little bit different context, she argued that if one has experienced empowering cognitive and behavioral changes, even if you have, so that we have an intervention that's improved people's knowledge and awareness, maybe their understanding of social norms, and has even allowed them to make some behavioral changes. She argues that it's difficult to maintain that one is empowered as long as those personal and interpersonal changes have no impact on socially unjust situations which continue to affect one's life. So I just want to end by thanking you. I look forward to your questions, and for more information, please contact the resources below. Thank you.